HIV is the virus. So HIV stands for human immunodeficiency virus. So that is the virus that causes the disease. And AIDS is the syndrome. So when talking about syndromes are a collection of conditions that have come together, and this collection of conditions is as a result of the non-functioning of the immune system.
So I believe this year we have a theme, which is overcoming disruption, transforming the AIDS response. But beyond the slogan, I mean, what powerful message is it sending to our communities and health systems, as well as everyone?
You bring about an important aspect, and I'll try and break it down for you in terms of our global targets. I'll start off by explaining something that is called 95-95-95.
Okay. Ladies and gentlemen, welcome back to another episode where we get to talk all things medical. My name is Audrey, your host, and I'm going to take you through a journey that's going to be very thought-provoking and has been evolving over the years, I think from time immemorial. So with me here today, I have someone who will introduce themselves and tell us what it is that they do, what they specialize in, and then we'll delve into today's topic. So over to you.
Thank you, Audrey. So my name is Tinashe Mudzviti, and by profession, I'm a pharmacist. I've been practicing pharmacy pretty much for close to 20 years now.
Okay.
And I work specifically in the field of HIV. And this is what I've been doing since 2008. On a day-to-day basis, I think I work in a clinic which has approximately 8,050 patients.
Okay.
So on a daily basis, we see approximately upwards of 200 patients living with HIV. So that is pretty much what I do.
Okay. All right. So you mentioned the issue of HIV. And I think growing up, there has been like misconceptions. HIV, AIDS. I mean, explain to us and our viewers, what is the difference between the two?
So when you talk about HIV/AIDS, this brings an important subject around the terminology that we use when we're talking about managing people living with HIV. HIV is the virus. So HIV stands for human immunodeficiency virus. So that is the virus that causes the disease. And AIDS is the syndrome. So when talking about syndromes are a collection of conditions that have come together, and this collection of conditions is as a result of the non-functioning of the immune system. Now the challenge is people tend to want to use the word HIV and AIDS together. But coming to 2025, we have a lot of people who live with HIV who do not have the syndrome.
Okay.
So terminology is important. So if you say to someone, you've got HIV/AIDS, you are combining the virus and the syndrome in one sentence.
Okay.
And yet this individual possibly is just a person with HIV. So terminology is important when we are debunking stigma and making our fellow friends more comfortable when we talk about HIV and we talk about AIDS issues. We need to separate the two.
Okay.
HIV is the virus and AIDS is the syndrome.
Okay. All right. So I believe this year we have a theme, which is overcoming disruption, transforming the AIDS response. But beyond the slogan, I mean, what powerful message is it sending to our communities and health systems, as well as everyone in and around the globe?
This year has been a special year. There are a sequence of events that took place that have made people with HIV and people who work in the HIV field quite uncomfortable.
Okay.
So earlier on in the year, I'm sure people have heard about the funding cuts.
Yes.
And the unavailability or the cutting of funding towards programs that support conditions like HIV.
Mm-hmm.
So clients and people who are working in the HIV field were worried about, will we have disruptions in access to care?
Yes.
So as we move forward, the one thing that we've learned this year is we need to have mechanisms and systems and structures in place such that even if there are disruptions in funding, in a specific funding mechanisms, we're still comfortable.
Mm-hmm.
So this has been what we've learned this year. We are in a place where our HIV program has grown in leaps and bounds.
Mm-hmm.
We have got people with HIV who are comfortable and who are doing well on treatment,
Mm-hmm.
and we don't want disruptions.
Okay.
We don't want disruptions.
Kind of like the COVID-19 kind of scenario where we have to live and we have to adapt and we have to manage, certain things, both, in country at a global scale, kind of a thing.
Exactly. So nowadays, for example, if you talk about COVID-19, we don't talk about it so much, but it is there, circulating. So it's the same place we want to go with HIV. Mm-hmm. We want to be in a comfortable place where globally there are no disruptions in care and treatment.
Okay, so we're talking about a global scale. So if we had to look at the global scorecard with regards to HIV, are we progressing? Are we regressing? Or, we're just in the middle? I mean, comparison, that is to say.
You bring about an important aspect, and I'll try and break it down for you in terms of our global targets.
Mm-hmm.
I'll start off by explaining something that is called 95-95-95.
Okay.
So from the UN AIDS programming,
mm-hmm.
they coined what they call 95-95-95 by the year 2030.
Okay.
And what 95-95-95 is all about is it's a model where we say, if we look at everyone on a global scale, mm-hmm. who is living with HIV, mm-hmm. we want 95% of everyone who is living with HIV globally, mm-hmm. first of all, to know their status, right? And then from that 95% of individuals who know their status, we want 95% of them, or at least 95% of them, mm-hmm. to be on antiretroviral treatment.
Okay.
And then from that 95% of individuals who are on antiretroviral treatment, we want 95% of them to be virally suppressed or to be doing well on treatment.
Okay.
So these are our global targets for 2030. I'm sorry to say, currently looking at our current numbers, mm-hmm. we seem not to be able to meet that target by 2030. Because currently, if we look at globally, mm-hmm. of the number of people living with HIV, only 77% know their status. Mm-hmm. Of that 77% who know their status, only 78% are on treatment, and only 73% are doing well on treatment. So on a global scale, we seem not to be hitting the target that we want for treatment outcomes. Mm-hmm. So if you're going to learn anything today, and if there's something called treatment as prevention, mm-hmm. take that home. TASP. Okay. TASP, treatment as prevention.
Okay.
The greater the number of people on treatment, mm-hmm. the lower the burden of the virus is. And the lower the burden of virus is, the less transmission there is going to be.
Okay.
So we are behind when it comes to hitting the global targets.
Okay.
One of the reasons is funding issues. We
right.
still have funding gaps. So we are there. I think if you look at 2025 compared to 10 years ago, we are far much better than we were 10 years ago. We're doing well. It's not a gloom and doom kind of picture. We are doing well, but there is a lot of wiggle room in terms of how much we need to do.
Okay. So you mentioned a very important aspect where you're talking about testing. So currently, the modern testing methods that are being utilized, whether at clinical level, at hospital level, private practice, public hospitals, are you confident in those tests? And do you think they bring about the actual results? So if I had to compare maybe the test that I get at a clinic versus the test I can get maybe at a private practice, they are modern, but do they give the same result? And are you confident in wherever you get that test done?
Let me say I'm definitely confident.
Okay.
This is when it comes to testing. So testing speaks into the first 95.
Yeah.
If we are not able to test, we cannot measure the first 95. So there is a host of testing platforms that are available, testing options.
Okay.
So, for example, you can walk into your pharmacy now and you can access a saliva-based test.
Okay.
The tests that you will get from your pharmacy, which we are now calling self-test kits, are your screening kind of tests.
Okay.
What they do is we are still at the screening stage.
Okay.
And once we've screened, the next step is you're supposed to get a confirmatory test, which is what you get from the clinic.
Okay.
Now, between your self-test and your clinic test, your confirmatory test that you get from your clinic test is more robust.
Okay.
And in the clinic, they have got algorithms which they use where they will use two different kinds of tests just to make sure that they can confirm the test result that you got.
Okay.
Now, with self-testing, the whole idea is, we've come from a place where there was a lot of stigma and people were afraid to get tested. People were afraid. You talk about, do you want to get tested? And
they'll shy away from it.
There was a lot of hesitance. You see, there was a lot of hesitance. People were not willing. So coming self-testing, we then realized, no, you can actually have someone test themselves at home.
Okay.
Because historically, we used to be afraid that if someone gets a positive test and they are alone, they might harm themselves.
Yes.
But now we're realizing we need to get people need to get tested. And people can test themselves and they can get a result, but it's a screening test.
Okay.
And it works very well as a screening test. Saliva-based and they're blood-based screening tests which you can access. Once you have a result, if it's a positive result, then you need to go for a confirmatory test.
Okay, so this is more extensive. So I'm going to assume it's like if I get the saliva-based one at home, and then if I'm going to walk into like my clinic, they're going to have to maybe draw blood, and then it goes through like a lab and they do the extensive testing to check things like your viral load, where exactly I am. Is that one of the things that we're talking about?
Well, you're close, but not exactly. When the platforms that we use for HIV testing, they are what we call antibody tests.
Okay.
So these platforms that we're using, they are actually not looking for the virus in you.
Okay.
The ones that you use in the clinic initially, they're not looking for the virus.
Okay.
They are looking for the antibodies that are made by the body to try and fend off the virus.
Is that like your white blood cells?
Exactly.
Okay.
Exactly. So those platforms, they look for the antibodies. Once they find that antibodies, then they can you are then given a positive diagnosis.
Okay.
It does happen that you can have something that's called an indeterminate test.
Okay.
But like I said, in the clinic, when you go in the clinic, they're going to use two platforms.
Yeah.
One will, if both of them are positive, then the result is definitely positive. But if one of them positive and the other one is negative, then it's indeterminate.
Okay.
That is when they can take a blood sample and then look for the actual virus.
Okay.
That then is PCR kind of test. So
right.
it's a bit more robust, and it's more conclusive, but it costs more.
Okay. All right. So also again, growing up out here, people say you look at someone, you can tell that they're HIV positive. I think they were like stereotyping more or less like it. But then again, I think it's because of the type of medication that was being given, especially in the 80s and the 90s. So it had side effects. So they would say, I can look at someone, I can see that this person is HIV positive. And I mean, that kind of a stigma. How then did it affect, our misconceptions about HIV? Because nowadays, I think modern medicine has advanced, and now you can't even tell, you get it. But during that time, that stereotyping, how did it affect? I mean, even someone having to take up, medication, and even now that we are in the 21st century and things this modern medicine, how is it affecting? I mean, potential risks and all of that.
So thank you. We've come from a place where 20 years ago, when recipients of care would develop the syndrome, one of the classic symptoms of advanced disease was a wasting syndrome.
Okay.
So your patient would lose a lot of weight. And it's unfortunate, these are the images that were portrayed during that time. Whenever we talked about HIV and AIDS, you would see someone who has lost a lot of weight, who has a wasting syndrome. And when the disease is advanced as well, one of the other classic features that you would see was the silky hair.
Yes.
So that era we have moved past that era. Modern medicine has made it such that we are having less and less individuals presenting with advanced HIV disease.
Yes.
Historically, when we had treatment programs, when they were developed, we used to have a specific subsection of patients living with HIV that we would treat based on CD4 counts. And I think historically, or long ago, traditionally, or 20 years ago, we used to talk about if someone had a low CD4 count, they need to go on treatment.
Yes.
We used to talk about if someone had advanced disease or had specific signs and symptoms, for example, if they develop TB, we need to start treatment for HIV. But now, we are now in the era of test and treat, and we're treating everyone.
Okay.
So there are less and less instances of individuals who develop advanced HIV disease.
Okay.
The wasting and the silky hair, we see less and less of it.
Okay.
The other thing is we now have friendlier drugs.
Okay.
Safer medicines. During that time, there were medicines like stavridine, for example. Stavridine was I remember in the clinic when it was the only NRTI available in combination with lamivudine and nevirapine. Our patients loved it because that was our first experience with ARVs.
Yes.
But stavridine was notorious for pins and needles. For peripheral neuropathy, it was notorious for something that we called lipoatrophy at the time.
Okay.
So the fat underneath your skin would actually disappear. So clients would have very, very thin legs and very, very thin peripheral limbs.
Yes.
Right? And you'd see the blood vessels and the veins, you would actually see them running through because all the fat would disappear. And I remember in the clinic we had one patient who actually went on a wheelchair because of the pins and needles. It was that bad.
Yeah.
So that era we've moved on from that era. Quite interestingly, one of the ARVs that we have, that we're currently using now, has been associated with weight gain. So specifically dolutegravir.
The contrast
is associated with weight gain.
Yeah.
We have looked at the data is quite robust now. The use of dolutegravir is associated with weight gain.
With weight gain.
Now, if you talk about weight gain in the clinic, there are two schools of thoughts. Some of our clients are actually okay with it because we are coming from a place where
it was associated with
wasting and weight loss was associated with HIV, and there was a lot of stigma associated with wasting. And now, if you have someone who has got a BMI greater than 30, they're looking healthy. So the stigma then just falls away. So, but we also now talk about, okay, the effects of being overweight and having unhealthy weight. The discussion then comes in. So it's when you're working in the clinic, we are now trying to strike a balance. Especially with our young patients.
Because I was now looking at things like diabetes and hypertension, which again, I mean, with weight gain, there are risk factors around that. Exactly. So I was now trying to, see, I mean, is there like a relationship as well that is associated with, HIV, diabetes and hypertension because of that weight gain? How then do you guys manage it going forward, especially with patients that are living with HIV?
So one of some of the work that we're doing now involves actually looking at that. Because fast forward to today, we've managed to, HIV is not a huge problem. It's not too much of a problem in terms of the virus. But then the non-communicable diseases have become a problem. So we've seen the weight gain. We've actually seen the hypertension. And we are still unclear about the diabetes mellitus, if the diabetes mellitus is associated with the medicine. But the message has become clear. We need to tighten up our management of the non-communicable diseases associated with
HIV.
With HIV. So I'll bring in the concept of what we are now calling the metabolic syndrome. So when talking about the metabolic syndrome, this is when a patient presents with three of either obesity, hypertension, diabetes mellitus, or dyslipidemia or hyperlipidemia. If a client presents with any three of these, then we say this individual has metabolic syndrome. Now, just living with HIV alone puts a client at risk of metabolic syndrome. Because when you're living with HIV, your body is in a constant state of inflammation. So just living with HIV alone puts you at risk of metabolic syndrome. Add on a medicine that is driving weight gain. That also then pushes metabolic syndrome. So our message and our focus right now is we need to make sure that if a patient has these non-communicable diseases, we treat. We make sure that we continually screen for hypertension, continually screen for diabetes mellitus, continuously screen for hyperlipidemia and treat. And then, of course, the discussion around weight gains is that's everyone's discussion.
That's everyone's discussion. Okay, so from the moment someone then hears that they are now living, with HIV, I mean, what does, treatment really look like? And life, what are some of the things that maybe change in their lives? So maybe if you can just take us through that, particular change in their life that they go through.
So the moment an individual receives a diagnosis of HIV, usually our first question is, whom are you going to tell?
Wow.
Whom are you going to tell? Because it's a diagnosis for life. You cannot keep this diagnosis to yourself for life.
True.
So support is important. Because you will not be in the same mental state for the rest of your life. So we will ask, who are you going to tell? Once we know whom we are going to tell, for treatment, we always encourage our clients to have a treatment buddy. Someone who can always check on them. Are you taking your
medication
as prescribed? Are you taking it properly? Are you okay? So we do want someone to have a treatment buddy, so that they continually have support for their treatment.
All right.
Now, we do have guidance in terms of the medicines that we start our clients on. So, like we said, nowadays we have got very, very robust and efficacious medicines. So, tenofovir, lamivudine, dolutegravir is what pretty much on a global scale, what pretty much the bulk of our clientele is receiving.
Okay.
And for lack of a better word, it works like a charm.
Okay.
It works like a charm. It's so then we start treatment, and then we make sure that we want to get our patients monitored. They come to the clinic when they're stable. We have clients coming to the clinic every 6 months, and it's great now when we say that the life expectancy of an individual living with HIV who is in care has pretty much reached the life expectancy of the general population, if not better.
So the way you're saying it, you make it sound so simple, but I know, yes, within the first few weeks of having to be diagnosed, it's real life changing, and it hits a patient really hard. So my question then becomes, like, what are some of those real life changes that they have to undergo in the first few weeks of receiving their treatment? I mean, from your experience, because you get to see these people on a daily basis, so you see what it does to them. So you mentioned the issue of support and everything, but what really happens in those first few weeks?
So in the first few weeks, I think patients struggle with the idea of having to take tablets for the rest of their life.
Okay.
Just the thought of taking tablets for the rest of their life is one of their major challenges.
Yeah.
I've had patients who will then come to me and say, it's the sight of the tablet. That is a constant reminder to me that I am now living with HIV.
Okay.
So these are the struggles that our clients will have to live with. You are now going into a schedule where, for a lot of them, you are setting an alarm, say at 8 o'clock every day, you need to be taking a tablet. You are faced with a bottle that you have to live with. Think about it. If you then have to travel, if you then have to visit your relative who doesn't know your status, if you have to go for a funeral, where am I putting this bottle? Right? I'm putting this bottle in my handbag, but it's a bottle of tablets where if you just shake it, it makes
a rattle, a noise. Yeah.
Makes a rattle.
Yeah.
And these are the things that our patients are struggling with. So I've got this bottle and it's making a rattle, and people are asking me, what's in your bag?
Yeah.
So it's the subtle things that they need to change in their lives, that things that they never really had to think of before the diagnosis.
Yeah.
Where am I going to keep my tablets? Who am I going to tell? What are people going to say?
Yeah. I think it's a bit of a challenge, even when we're looking at it, even from a workplace perspective. I know some companies, they have to have their staff members routinely have like the medical examinations.
Sure.
Or, when you start a job, you have to undergo like medical examinations. And I think it's something that a lot of people then try by all means to shy away from, especially if they're not comfortable with having to actually, reveal their status.
True.
I think because of the stigma that, has been there throughout, the period that we've been in. But I'm really hoping that people, even as they're listening to this podcast, they also get to understand that it's just like any other chronic condition. that we face on a day-to-day basis, you know. So yeah.
Yeah, great. So one of when talking about the workplace, one of the challenges we've also had with our clients have to face is earlier on when you get the diagnosis, you need to go to the clinic more frequently.
Yes.
So it means at work, I'm away today.
Yes.
In 2 weeks time, I need to go to the clinic. I need to take an off day again. A month from today, I need to go back to the clinic. And my HR manager keeps asking me, so where are you going? You see, so the dynamic of someone who needs to go to the clinic every month seems simple. But when you think about having to take time off work,
yes.
and at work you don't want your status to be revealed, people keep asking you, why on a month, every month on the 20th, you're away, what's going on?
Okay.
So our clients will face these kinds of struggles in the workplace environment.
So how best would you advise, I mean, for workplaces to be a bit more inclusive, maybe having to, not just having the, you know, AIDS policy as part of your policies, but what else would you maybe advise people in the workplace to be cognizant of, especially not just maybe for HIV, but even other non-communicable diseases? What should we be open-minded to when we're considering such cases?
I think workplace environments should be more accommodating.
Okay.
And they need, I mean, it's good to ask questions, but don't be too involved in someone's personal things.
Okay.
So if I think of it, if I was to become an HR manager, and then I realize that there's a frequency for someone once a month to keep getting a day off, we need to start learning to let things go and accommodate people, especially when they go to the clinic. Sometimes clinic hours are quite lengthy hours.
Yes, they are.
You spend a lot of time in the clinic. The workplace has to accommodate individuals.
Okay. All right. So maybe moving from the workplace, I understand some cultural religious beliefs have always put, you know, people a bit more at risk for HIV. And how do you confront these sensitive issues without having to attack someone's identity?
So, for religious beliefs, I'm sorry, but that's a painful one.
Yeah.
Our experience with religion has sometimes not been the best. I can cite an experience where, so religion and faith move together.
Yes, they do.
And in faith, there's they say that if whatever you believe, you can make happen.
Yes.
So if you can believe that the HIV will be cured, if you truly believe, it will happen.
Yes.
Now, this is for me, it's a controversial statement as a pharmacist and as someone who has got their own religious background, because we've got experiences where, for example, a 14-year-old goes to church X, and then their pastor tells them, your faith is what is going to heal you from HIV. And if you truly believe that you are healed, you will stop your antiretrovirals immediately. Because that's the sign of faith.
Yes, it is.
You can't say I've got faith if you then go if you go home today and then take your ARVs. Now, we've had these experiences before in the clinic, and we've had to call in patients and say, no, we're fine. We understand you were healed, and we want to congratulate you. If you're truly healed, please come through for an HIV test. And to date, no one has tested negative. To date, I'm not disputing that there is faith and faith works, but I'm only talking of my experience. To date, no one has tested negative.
Okay.
So our messaging has been now to collaborate with pastors with this kind of a religious background to say, look, this is detrimental to the health of our patients. If you truly believe you can heal someone, that is fine. As soon as they are healed, tell them to come to the clinic for testing, or allow them to get a self-test.
Okay.
Because it is detrimental for someone to stop treatment for a lengthy period, because the viral load will go up, and that is quite harmful to
So
the patient.
you now mentioned the issue on faith and religion. So I have a question to say, has anyone who has undergone treatment for whatever period ever gotten to a stage, now we're talking science, whereby they're like, I have been cured from HIV?